high cholesterol is a death sentence. It's not. It doesn't have to be that way. In fact, high cholesterol is not the major cause of heart attacks. Something else is. You see, if it were all cholesterol, we would have, over the past 30 years, have cured heart attacks because medications lower cholesterol. But we haven't cured heart attacks. There's something else going on. You see, most people really don't understand cholesterol. And that's really not a surprise because most doctors don't understand cholesterol either. So docs need an easy button. They are very busy. The easy button is check the cholesterol. If it's high, write a script. But we all know that's just not the answer. Let's go deeper. Cholesterol is not a toxin. It's not a sludge creeping through your veins like some villain in a health horror movie. Cholesterol is a waxy, fat-like substance. And guess what? Your body makes it on purpose. Why? Because it's essential. Cholesterol is used to build your cell membranes, literally the walls of every cell in your body. It's used to build vital hormones like testosterone, estrogen, and cortisol. It's used to build vitamin D, which regulates immune health and inflammation. And it's a major component of your brain. About 25% of your body's cholesterol is up here, helping neurons fire and memories form. So no, cholesterol isn't the bad guy. It's the brick, the mortar, the wiring that in this house that's you. It keeps your biology running smoothly. The real question isn't, is cholesterol bad? It's what happens when cholesterol is in the wrong place, at the wrong time, in the wrong context. Meanwhile, the real villain has been running a crime syndicate in our bloodstream the whole time. So why do we call it good or bad cholesterol? Here's something that might surprise you. HDL and LDL are not just cholesterol. I'll say it again. HDL and LDL are not really cholesterol. They're actually lipoproteins, little transport vehicles that carry cholesterol through your bloodstream. So think of them as like little Uber drivers, and cholesterol is just the passenger. HDL is a protein, the Uber and the Uber driver. It's the car that picks up the cholesterol, and it takes it back to the liver. It's been called the good guy because people see it associated with good, healthy metabolism. LDL, on the other hand, tends to go up when people's metabolic health begins to decline. That's why they call it the bad cholesterol. So naturally, it got stuck with that name and that label, and it has not gone away. But here's the problem with that logic. Calling HDL good and LDL bad really oversimplifies a much more complex system. It's like saying fire trucks are dangerous because you always see them at a fire. LDL's not out there trying to kill you. It's doing its job, delivering cholesterol where your body needs it. The danger comes when inflammation and damage in the arteries create an environment where that delivery becomes a problem. That cholesterol starts to just slip right through inflamed lining of the artery, the intima. Now, here's the most important clarification. Whenever you see in your lab report LDL-C or HDL-C, they're referring to the cholesterol inside the lipoprotein. The HDL is the lipoprotein and the C is the cholesterol in it. The passenger inside the car that's being transported. Now, the oversimplified narrative leads people to panic when their LDL goes up, even when everything else looks good. And I'm questioning that. I've seen too many upset people over this specific issue. It leads doctors to prescribe medications, big medications, not harmless medications, because of a number, without asking, why is that number changing the way it is? Just treating a number. Blaming LDL for heart disease is like blaming Amazon for porch pirate theft. You know, there's more to it than that. Just because they dropped off the package doesn't mean they stole your bike or your package. Now, the next logical question is this. If LDL is not the villain, then What makes it into one? Why does it get the rap? Other than that association, does it actually do any damage? Let's talk about the story we've all been told. LDL clogs your arteries. LDL causes heart attacks. LDL is the enemy. It's a clean, simple headline. But medicine really isn't that clean, and it's certainly not that simple. This narrative goes all the way back to the diet heart hypothesis from the 1950s. There was a theory that was involving saturated fat, saying saturated fat causes cholesterol, and the cholesterol causes clogged arteries, and that leads to heart attacks. That was really popularized by a fellow named Ancel Keys. He connected fat intake and heart disease using something called the 7 countries study. But here's one thing to think about. Look it up. He looked at 7 countries. There were over 20 countries that he had the data for. But these 7 countries actually had data that fit his hypothesis. He didn't use the other ones. The ones that didn't fit the theory, yeah, he left them out. That's not good science. This idea that dietary fat raises cholesterol and that LDL clogs arteries, that became gospel. To a large part because of Ancel Keys' work, the entire treatment protocols were built around lowering LDL at any cost. But science has moved forward, and the data got deeper and more nuanced, and suddenly things just weren't adding up. Because if LDL alone was the villain, how do we explain all those people with perfect LDL? Perfect LDL still getting a heart attack, or very low LDLs getting a heart attack. What's that all about? Well, of those with high LDL and zero plaque, wait a minute, that's sort of like the flip side of this script. What's that all about? It's sort of like blaming traffic jams on the number of cars without thinking and noticing that the street's torn up. There are a bunch of potholes in it, and the stoplight's broken. And then there's a guy next to you texting, and all of these things are problems, not just the number of cars. So if LDL isn't the whole story, then what is? Let's look at what really causes plaque to form and why LDL needs a very specific environment to become a threat. Because the rabbit hole goes deeper than just cholesterol levels. And what we find at the bottom is inflammation. And I'm going to repeat something I've said before. You go back, you talk to your internist or your cardiologist or your lipidologist who's just treating LDL alone. Their standards committee all said, don't do that. Don't treat a number alone. This is a deeper discussion. What does the evidence really say? Now, let's be clear. LDL does play a role in atherosclerosis. It is not innocent, but it's also not the full story. LDL becomes dangerous when, and only when, the conditions are right for it to become oxidized, inflamed, and trapped inside the artery walls. LDL might be the match. Maybe inflammation and metabolic dysfunction are more like the gasoline. Now, what about people with familial hypercholesterolemia, genetically high LDL? We have tons of those patients. And until the low-carb diet and successful low-carbing became so popular, that was the major source of seeing patients with LDLs of 200 and higher. But now we get a lot more of the lean mass hyperresponders. We'll talk about those a little bit later because that's a whole different issue in terms of cholesterol. Now, even if your typical familial hypercholesterol patient does have a higher risk of heart disease. But here's what's fascinating. Not all of them develop atherosclerosis. They have the LDL levels that would do it, but for some reason they're not developing it. And having seen tons of them, I can tell you why. Those who don't form it, they tend to have low inflammation, great insulin sensitivity, and healthy lifestyles. So even in extreme cases, LDL is not acting alone. If you've ever been told your LDL is high, you need statins, you really deserve a deeper look. Because a number on a blood test doesn't tell the whole story. So we need to zoom in on what kind of LDL and how many particles are actually circulating. Now that's where ApoB comes in. ApoB is a protein on the surface of LDL particles. That's the protein it's like the Uber car and the driver. Each particle that clogs arteries carries exactly one ApoB, so it's a direct particle count. More particles equals more chances for one to slip into an inflamed artery wall. remember, inflamed artery wall. So, yes, ApoB can be a more precise marker than just looking at LDL cholesterol, the cholesterol content. The other thing about ApoB is that it tells us about other particles that are far more related to plaque formation. The big ones, the triglyceride-laden particles. For the geeks, it's the IDL, intermediate density lipoprotein, chylomicron remnant, VLDL, very low density lipoproteins. You don't need to remember all those geeky terms. Thanks for putting up with them. Now, let's go back to something else, something related, Lp(a). It's related. It's sort of an LDL. The particle is very similar, but not quite the same. It's a genetic variation of LDL. Lp(a), the wild card. You may remember the show, The Biggest Loser. Bob Harper was a very fit fitness trainer on that show. He was in his early 50s and working out when he had his own heart attack. He came on later to say it was Lp(a). Now, let's talk about that. Lp(a) is like LDL's misbehaving cousin. It's genetically determined. It's harder to influence with diet, and it's stickier, meaning it may promote clotting and inflammation inside arteries. It may also be a little bit more like the fire truck than the arsonist. I hate to confuse things, but unfortunately, that's the real situation. That's the reality. High Lp(a), it's a red flag worth watching, especially if you have inflammation or a family history of heart disease. It's like having a mischievous uncle at Thanksgiving. Sure, he's family, and he can start off a little bit funny, but then once he starts drinking, dancing, throwing mashed potatoes, you've got a situation. Sort of like Lp(a), maybe. Now, LDL does matter. We've said that before. Let's go back and talk about LDL, ApoB, and Lp(a). They all matter. But what determines whether they're dangerous or not is really inflammation. That is the driver. And that's where most doctors and most treatments get it wrong. Let's dig into the real enemy inside the arteries, chronic inflammation, the true culprit behind clogged arteries. So what causes all the inflammation? There's got to be a cause here. Enter the real villain, metabolic disease. This is the modern-day pandemic almost nobody talks about. Metabolic dysfunction. It includes insulin resistance, high blood sugar, high triglycerides, visceral fat, and low HDL. Even without high cholesterol, these conditions silently fuel inflammation, damaging your arteries and paving the way for heart disease. So this is why I changed how I treat patients. Because I've seen people with low LDL and clean labs drop dead of a heart attack. I've seen other people with high LDL, but no inflammation, no insulin resistance, that are thriving. Bottom line, we've been fighting the wrong battle. It's not about how much LDL you have. It's about how inflamed your body is when that LDL shows up. It's like leaving a pile of wood in your backyard. On its own, it's not a big deal. But if your neighbor's lighting fireworks and grilling with a blowtorch, you end up with a house fire. So how do you know if your body's inflamed? What labs should you really be looking for? Let me show you how I assess inflammation and why it changes everything. Number 1, C-reactive protein, or HSCRP, stands for high sensitivity C-reactive protein. This one's simple. It tells me that there's chronic low-grade inflammation happening under the hood, under the surface. And yes, it's just like a smoke detector. It'll scream if there's something burning, even when you can't see the fire yet. Now, optimal value below 1.0 milligrams per liter. Above 3.0, that's a red flag. Your arteries may be inflamed right now. Now, do remember that it is the most common for having what we call a biological false positive. That means a false positive due to something else going on in the body. I'll explain. I've always had well below 1 on my CRP, except once, and it was over 10. I had just had a massive sore throat. So CRP is a reactive protein made by the liver reacting to anything, a viral infection, a cut, a bruise, things like that. So it's not the most specific. It's not very specific. It tells you something inflammatory is going on, but it doesn't tell you what. So of the doctors that do look for cardiovascular inflammation, most of them just look at CRP. You need more than that. Now, I mentioned getting clearer and making sure that we're focused on the arteries. Myeloperoxidase, it's also called MPO. This one goes deeper. It's an enzyme released by white blood cells in the artery. When it's elevated, it's often a sign that the body is actively attacking your arteries. Optimal values, below 470 millimoles per liter. Think of it like this. If HSCRP is the smoke, myeloperoxidase might be the match. You know you're getting some fire there. It's like having a SWAT team patrolling your blood vessels. Sounds cool until you realize they might be kicking in the doors of your friend's family, your side. In other words, you might be taking friendly fire. That is the problem with myeloperoxidase. Number 3, microalbumin to creatinine ratio. Now, this checks for kidney damage technically, and a lot of docs know to do that, but they don't understand the impact for vascular disease, and they don't understand what's called microproteinuria, very low values of protein in the urine. So, importantly, it shows me if your vascular system is leaky. When is it leaky? When you've got inflammation of the lining of the artery wall. Inflammation makes your blood vessels porous. And when I see inflammation slipping into your urine, I know that your blood vessels are under attack. Optimal values, below 3 milligrams per gram. Number 4, lipoprotein-associated phospholipase A2. That's a big word. Let's just call it LPPLA2. Or another word, another name, plaque 2. Just call it LPPLA2 or plaque 2, either one. This one's huge. It tells me if your LDL particles are getting oxidized, if they're turning into plaque-forming missiles. It's incredibly predictive of future cardiovascular inflammation and even events. So again, this is one of the most important ones from my perspective because it's the one that really tells us what's going on in the lining of the artery wall. That lining in the artery wall goes into the kidney and keeps you from spilling protein into the urine. So if you're spilling protein into the urine, even these microscopic amounts, we know you've got some damage to the lining of your artery wall. Optimal value should be below 123 nanomoles per minute per milliliter. When I run these labs, I'm not chasing numbers. I'm looking for signs of an actual threat. Because the goal here isn't to treat a lab report. The goal is to prevent you from becoming the next sudden heart victim that no one saw coming. It's like checking your oil light and saying, well, the car still runs. Maybe we should ignore it or hope it gets better until you're on the side of the highway Googling tow truck near me with 1 bar of signal. So, once we know inflammation is present, or better yet not, what do we do about it? Let's talk about the number 1 worst mistake doctors make when assessing cholesterol. Unfortunately, it happens all the time. Here's the typical scenario. You go in for your annual physical, they draw blood, they check your lipid panel, cholesterol. Maybe if you're lucky, they also test ApoB. And if you're really lucky, maybe they throw in a CRP, C-reactive protein. But the doctor walks in, he's got a frown on his face, and he says, your LDL is elevated. We need to lower it below 70. And the solution? Let's start you on a statin, high dose, and you need to start the Mediterranean diet. Plenty of grains. But here's the problem with that approach. It misses the bigger picture. Problem number 1, ignoring metabolic disease. Most doctors aren't even assessing the real root cause of clogged arteries, which isn't just LDL. This is science. This is not my opinion. 3/4 of docs don't know how to diagnose prediabetes. Multiple groups have looked at that. Groups from Harvard, groups from Hopkins, Mayo, and have shown docs just don't know how to diagnose prediabetes, let alone treat it. It's metabolic dysfunction, insulin resistance, high blood sugar, inflammation, visceral fat. These are the things that we need to be looking for. And while Mediterranean diet is better than the standard American diet, all those grains, even if they are whole grains, look up the glycemic value of whole wheat bread. It's higher than table sugar. That's problematic for people with insulin resistance or prediabetes. So we're treating a number on the surface without fixing the underlying fire. Problem number 2, overprescribing high-dose statins.
Tired of being told your labs are normal while you still feel off? Meet Dr. Ford Brewer, a YouTube sensation with over 600,000 subscribers, dedicated to helping you optimize your health and metabolism.
My team is offering free clinical consultations to create a tailored program just for you. No guesswork, just real data, real care, and real results.
Call now and take control of your health today.
The second issue, docs love prescribing high-dose statins. They know they'll lower LDL aggressively. It's simple, it's very easy, doesn't take much time. They can get in to see the next patient and create another billable service for their insurance company. But at what cost? Side effects are more common than most admit. Muscle pain, fatigue, insomnia, blood sugar spikes, yes, even cognitive issues, memory loss, brain fog in some patients. I've had patients who felt awful for years, only to realize it was the statin, not the aging, that was robbing them of their energy. And we switch to a lower dose or target inflammation instead of LDL. When we do that, suddenly they start feeling good again. Now they're alive. Problem number 3, lowering cholesterol too much. The third issue is the most overlooked. Lowering cholesterol to extreme levels has real risks. When you drop LDL below 70, you're also lowering your body's ability to make hormones, build cell membranes, maintain brain function, repair tissue. And when the LDL drops below 50, people start to feel it. Brain fog, low libido, mood swings, fatigue, and in some cases, increased risk of certain types of cancer and hemorrhagic stroke. Now, there's been a ton of evidence collected about statins and statin side effects. Many would say they're overblown, and a lot of times they are overreported. But here's the problem. As a doctor, somebody comes in with statin side effects, you should first assume that's real and treat that before ignoring it. Ignoring a true statin side effect can be a big problem. But doctors often don't do that. They often say, that's probably not real, and just discount it and move on. Cholesterol isn't just something to get rid of. It's a raw material. Your body needs it. It's like draining the oil from your car because you have a leak. You're scared of the leak. You say, okay, I'm going to stop that leak. I'm just going to drain the oil out. I mean, that's kind of silly, but it's also kind of silly to do that with statins too. There's a time and a place for them. High-dose statins, every time you see that number, is not the right time or place. So what should we be doing instead? We need to stop obsessing over just one number. We need to start treating the metabolic environment, the context that the cholesterol is living in. Because if we get insulin resistance under control, we reduce inflammation, we improve metabolic health, there's less opportunity for cholesterol, for the lining of the artery to get damaged by cholesterol seeping through that injured intima. Plaque doesn't just pile up in the lumen where the blood flows. That's what most people think. It actually slips through injured lining called intima, but it can't get through the next lining, the next layer called media. So instead of actually piling up in the middle, inside the artery, it's piling up between the layers of the artery wall. That's something that has to do with events. We can talk about that later. But right now, let's talk about how to lower inflammation and cholesterol the right way with lifestyle changes that actually work much better than medications. Here's what I do instead. Number 1, diet. Now, a low-carb diet or carb-conscious diet works wonders for one reason. It addresses the root cause of metabolic disease. Insulin resistance. What's that got to do with the root cause? Insulin resistance, just anytime you hear us say that or anybody else, just think can't digest carbs. That's all insulin resistance really is. When you reduce carbs, especially refined carbs, you lower your blood sugar, usually your blood pressure, your insulin levels, your triglycerides, and systemic inflammation. Your HDL tends to go up, and your triglycerides go down, and your metabolic health improves very quickly. I've seen patients go from pre-diabetic, even full diabetic, to even insulin sensitive in just a few months, simply by reducing carbs, processed foods, and losing body fat. The best part? That improves lipid markers, cholesterol markers without medication. We used to think cutting fat was the answer. Meanwhile, people were living on rice cakes and low-fat cookies, wondering why they felt like garbage. Number 2, exercise. You don't need to spend hours on a treadmill. In fact, short bursts of intense movement, like HIIT, even re-HIIT, reduced exertion, high-intensity interval work, are more effective for improving insulin sensitivity, mitochondrial function, your body's ability to burn fat for fuel. Just 2 5 to 10 minute sessions in a week can create real metabolic change. We're not talking about marathons here. We're talking about short bursts. Exercise is one of the fastest ways to reverse insulin resistance. Yet most doctors still only recommend walking more. Walking is good. You need some of that. You don't need to jog. Walking is helpful. But you got to have more than just aerobics. You need the intensity work. Now, I'm not saying mall walking doesn't help, but if your workout routine involves Aunt Carol's, a pretzel, a Bath and Body Works stop, it's probably time to level up a little bit. Number 3, how I use statins differently. Do I use statins? Yes, I do, and I get pummeled by the low-carb community. I don't use them the way most docs do. I don't use high-dose statins. I don't even use mid-dose statins. And I'm not really trying to crush LDL in levels into oblivion. I use low-dose statins for one purpose: reduce vascular inflammation. Statins work by blocking an enzyme in the liver called HMG-CoA reductase. That helps make cholesterol. So you got to be careful, and you don't want to crush all of that activity. Sometimes, though, it helps to slow down something else. What's the something else? The same pathway also produces substances called isoprenoids. What is an isoprenoid? They play a role in activating immune responses, including inflammation inside the artery walls. By reducing isoprenoids, low-dose statins can also lower oxidative stress, reduce immune cell activation in arteries, and improve endothelial function, how your arteries respond to blood flow. In plain English, they make your arteries less irritated, less inflamed, less likely to form dangerous plaque. They make them healthier. That's what we need, healthy arteries. The evidence? Oh gosh. Some of the first evidence started over 20, maybe 30 years ago with the Jupiter trial. You remember that? Jupiter, like the planet. It showed even people with normal LDL levels, if their C-reactive protein was high and they took statins, cardiovascular risk dropped significantly. Again, it wasn't high-dose statins, it was low. So in many cases, it may not just be the cholesterol drop that helps. And in fact, I don't think it is mostly the cholesterol drop. It's the fact that the statins calm the fire. They cause the fire to decrease, to go out, the fire in your arteries. Now, for that, we use low-dose rosuvastatin 5 milligrams or pitavastatin 1 or 2 milligrams a day. And you don't even have to take it once a day. We've got plenty of patients taking it 3, even 2 times a week, some taking it once a week. I take rosuvastatin 5 milligrams twice a week. And I don't use them, as I said before, we don't use them to decrease blood levels. We use them if you have plaque. Because if you have plaque, you're by definition now a cardiovascular disease patient. Now, you ever hear of CIMT, calcium score, CT angiogram? If you have a positive CIMT, plaque on CIMT, or a positive calcium score or CT angiogram, at that point, believe it or not, you're now a cardiovascular patient. I'm a cardiovascular patient because I have plaque. And guess what? I'm 67 years old. 98% of 67-year-old males have plaque. So I do take rosuvastatin 5 milligrams twice a week, as I mentioned before. There are other options. Sometimes I combine them with ezetimibe, not very often. Sometimes alpha-lipoic acid, again, not very often. It depends on the profile. We even use the new lipid-lowering drugs, the PCSK9 inhibitors, because, as I mentioned before, we've got a lot of FH, familial hypercholesterolemia patients, and a lot of lean mass hyperresponders. And some of those want to chase that LDL down a little bit lower. And I understand fully why. Now, I know PCSK9 sounds like a Star Wars droid. Thank you so much for hanging in there with me on that geekiness and all those geeky terms. Stick with me, though. This is important. I'm going to go a little bit deeper into what that actually is. The simple version is this. Your liver is constantly cleaning LDL cholesterol from your blood. That's how it picks it up. So it uses LDL receptors. It's like, think of it as little catcher's mitts that stick out into your bloodstream catching LDL. Think of them like little Pac-Men gobbling up LDL particles. Your body also makes a protein called PCSK9. Its job is to destroy those LDL receptors. So the more PCSK9 you have, the fewer receptors, the higher your LDL goes. Does that make sense? I hope so. If not, you can replay that, or we can just go on. Here's the thing. When Repatha steps in, it's a monoclonal antibody. It's just an antibody that blocks PCSK9s. It inhibits them. It stops that protein from destroying the LDL receptors. The more receptors, the more LDL is cleared out of your bloodstream. So these drugs are very, very effective at lowering LDL levels fast and significantly. But there's a group of people to whom I often discuss PCSK9 inhibitors. First of all, let's talk about familial hypercholesterolemia. It's a genetic disorder. People have very high LDL levels from birth. We're talking 200, 250, 300, even more. And yes, it does increase the risk of cardiovascular disease. Not so much in these lower levels of 2 to 300. Those are what we call heterozygous. They just got one FH gene from mom or one from dad. They didn't get both. But when some kids get one from both parents, that's called homozygous, their LDLs can shoot up to 500 or more. And those kids often have significant risk, even as teenagers or 20-year-olds. Let's go back to the typical heterozygous patient, 2 to 300. It increases the risk of cardiovascular disease, but not that much. There's a misunderstanding around this. People with FH lack the receptors needed to clear LDL from the bloodstream efficiently. So LDL levels climb, and they stay high. And yes, if left untreated, FH can lead to early heart disease. We've seen cases of heart disease even in the heterozygous patients, maybe as in the 40s. But here's what most people don't hear. Not everyone with FH develops plaque, and not everyone with FH dies young. Why? It's pretty clear. LDL is not the only risk factor here. Just like everyone else, the risk still depends on inflammation, insulin resistance, oxidative stress, and lifestyle. The evidence shows the following. People with FH who are metabolically healthy and who live anti-inflammatory lifestyles don't get heart disease at the same rate as those who smoke, eat poorly, have high insulin, don't work out. So once again, it's the context that determines the risk, not just the number for the LDL. Here's how I treat FH patients. When I work with FH, familial hypercholesterolemia, I always go deeper. Yes, we may use medication. And yes, that's a group where we can sometimes use the PCSK9s, especially if there's known plaque or high inflammation. But we also test for ApoB, C-reactive protein, Lp(a)2. We evaluate if they have plaque. We prioritize metabolic health, low-carb nutrition, strength training, sleep, stress management. In many cases, we combine a moderate LDL-lowering strategy with a strong metabolic support plan, because that's where long-term risk gets controlled. So if you've been told you have FH and feel like it's a death sentence, it's not. It is not. It does mean you should be proactive, though. Don't panic. Be precise. Be proactive. You can take that risk off the table. So what happens if you go low-carb, feel great, lose weight, but your LDL shoots up? Don't panic. We're going to talk about that group of people. I mentioned them a ways back when I was talking about really high LDLs. These people are called lean mass hyperresponders. So what is a lean mass hyperresponder? These are typically very active individuals with low body fat and great insulin sensitivity and a very high-fat, low-carb diet. Well, their LDL skyrockets. But here's the twist. HDL also goes way up, often well above 70. And triglycerides drop, sometimes below 50. And insulin is fantastic. It's going down too. So this is not like your typical person with a high LDL. Their triglycerides are low instead of high, and their HDL is high instead of low. In other words, these people are metabolically very healthy, yet their LDL is going up. Now, the reality is there's a bunch of debate about this right now because we are seeing so many of them. When your body shifts into fat-burning mode, it relies on fat and cholesterol transport via LDL particles to move energy around. So, LDL goes up not because you're sick, but because your body's adapting to a new, efficient, fat-burning fuel system. It's like increasing the number of trucks on the road or the number of boats in the harbor. That's the analogy Dave uses. Not because there's a traffic chaos, but because business is booming. In other words, there used to be very little fat energy business. It was all carb energy business. Now, not very much carb energy business going on. So the trucks on the road or the boats in the harbor are now carrying fat because the business is booming and the delivery system is working better than ever. So you see a bunch of these empty boats. The LDL particles are empty boats. So what do I do with these folks in these cases? We've got a ton of hyperresponders, lean mass hyperresponders. First, I don't treat the LDL number. I don't recommend that we do that. I assess the risk. I run C-reactive protein, Lp(PLA2), fasting insulin, and some kind of imaging, either CIMT, carotid intima media thickness test, or calcium score, or coronary CT angiogram. If I get a CT angiogram, I'm going to get an AI analysis with it. And those really are the state of the art. They're more expensive. They're $2,000, but they do give you a very, very good understanding of your plaque. If all of that shows very low risk and the patient is thriving metabolically, I don't push to change a lot of things. We don't lower a number at the cost of somebody's well-being. A number? That's what you see in most of medicine. Very simply, look at the LDL. If it's high, you don't worry about whether they've got plaque. You don't worry about their metabolic disease. You just treat that number. We don't do that, especially when that number doesn't appear to be reflecting a lot of danger. But this leads to the following question. How do we reframe all of this? Instead of asking, how do I lower my LDL? That's what you're getting in most of the medical community right now. We're asking a slightly different question. Is my LDL elevated in a context that's actually harmful? Because in medicine, context is everything. It's like seeing a fire truck outside your house and assuming your kitchen's on fire, when really they're just grabbing a cup of coffee at the coffee shop across the street. But this is where it gets really interesting. The debate. You see, a new study came out recently. It suggested that plaque causes more plaque and not necessarily LDL alone or the new fad, ApoB. It's turning that old model upside down, and the medical community is split. Some folks are glad to see it. I'm glad to see it. The typical low-carb community content creators glad to see it too. But we're different from the typical low-carb community because we think that there's still a place to be looking at LDL. And we'll talk about that in a minute. Let's talk about the controversy right now, though, and what it means for the future of heart health and longevity. A few weeks ago, a preprint study hit the headlines with a bold claim. Plaque begets plaque. Not ApoB, not LDL. Meaning, once plaque is present, it creates the conditions for more plaque to form, regardless of LDL or ApoB. Now, at first glance, this sounds like a paradigm shift. But then the critics showed up. They had a few points. To me, the points were overblown, and there was maybe a little bit of, could have been handled a little bit better. We'll talk about that too. As many times as I've talked about methodological problems, now I start tripping over that word. Sorry. Anyhow, methodological issues started to appear. Like this. Many of the subjects were already high risk with existing disease. To some people, that was a methodological problem. To me, it's not a methodological problem at all. It's a methodological strength because we want to watch those people. The second methodological problem, plaque still progressed, quote, rapidly, end quote, even in those with lower ApoB. I think there's a lot of question right now about the term. Yes, there was clearly some plaque progression. There's no question. I think there's going to be a lot of redefinition of just how rapidly that plaque progression happened. The third methodological problem was the authors could not confidently isolate ApoB's role. Well, that's not a methodological problem of this study. It's just not. I mean, that's what the whole medical community is trying to show. I mean, the medical community overall has gotten a little bit over its skis. And here's what's happened. If you look at the actual standards committees, the guys that are telling internists, cardiologists, family practitioners what to do, none of them ever, there was never an American Board of Internal Medicine, any of these groups that said, look at the LDL and treat it with a statin. That was never the opinion of the experts, ever. But what happened was that was the easy way to do it. So that's the way doctors just started doing it. And so now we should be surprised that something else is going on. Let's go back one more step. Even when the typical doctors and the typical groups in medicine said, hey, there's a thing called LDL discordance, meaning the LDL's levels really didn't fit the level of risk. That's actually what gave rise to this focus on ApoB. According to Tom Schneiderman and several others, I couldn't agree with him more. He says ApoB is far better than LDL because ApoB tells us about metabolic disease. I'm not going to go into the technical aspects of it, but that's what Tom Schneiderman said in his article, and I agree. Here's where I disagree, that ApoB is not the best way to look at metabolic disease. Triglyceride over HDL is a great way, but doing a Kraft insulin survey, an OGTT, an insulin response, even looking at fractionation, those are so much better ways of looking at metabolic disease than an ApoB. So those of you who are familiar with some of the more subtleties of this debate may be saying, there's a little bit of a storm in a teacup going on here. We've always known metabolic disease was a huge issue, in many ways bigger than LDL. We just kept seeing LDL, for the most part, correlating, going up when you had metabolic disease. But now we've found this subgroup where it's going just the opposite. So why is everybody saying LDL doesn't matter on one side and then another side saying, oh, yeah, it's all LDL? Again, we've got a storm in a teacup driven by bad habits. The bad habit of treating a number, an LDL number, not the patient. And again, the standards of internal medicine were never to treat a number. So let me talk a little bit more about what I think the truth is, what I think this means. Number one, the science is still developing. Adrian, Nick, and Dave, all three, from day one, I know all three of them, not a single one has ever said LDL doesn't matter. You know who says that? The low-carb community, the guys that want to say LDL doesn't matter. What they have said, though, is there's this interesting group, and maybe this interesting group does indicate that metabolic disease is more important. And you know what I think? Clearly, metabolic disease is more important than LDL. So we're still learning how plaque forms, why it progresses faster in some people, and how markers like LDL, ApoB, and inflammation interact. But I'm going to go back and clarify. Remember, I said markers like LDL and ApoB. I think LDL and ApoB can have an activity, but I really think they're more markers than anything else. I don't think they don't matter, but I think metabolic disease is far more important. And at the end of the day, we've all known that from day one. You don't have to be a doctor. You don't have to be a scientist. You just have to ask the question, who's healthier? Who's going to have a heart attack? Somebody with an obesity problem or somebody who's thin and doesn't have a lot of metabolic disease? Duh, we all know that. If we all know that, that's why I come out with all of the drama right now and the debate, a little bit of a storm in a teacup. This new data does not throw out what we know. It just reminds us there is no single cause, no one-size-fits-all answer. For example, smoking has always been a kryptonite for arteries. It always will be. Cigarette smoking. Rheumatoid arthritis has always been kryptonite for arteries. Always will be. So these two things are not metabolic disease. They're not LDL. They're not ApoB, and yet they rot arteries very quickly and cause heart attack and stroke. So let's back up and look at what we've known all the time. This helps create some new focus and hopefully, more than anything else, It's going to get the doctors that tend to just treat to a number, an LDL number, to back up and do what their standards committees always told them to do. Take your time, evaluate the risk. Don't just look at a number. So what doesn't change? Our approach stays the same. We always test. We don't guess. We look at inflammation, insulin resistance, particle count, and plaque burden. And we treat people individually based on their risks, their labs, their lifestyles, and goals. Because medicine isn't just about studies, it's about people. Which brings up another point that I always say. I talk to the patients and I say, look, there are some things we know, some things that we don't know. I want to make sure you understand the details around this debate, especially if this is a lean mass hyperresponder patient of ours. I make sure they understand the debate, and I tell them what I would do if I were them. Some of my lean mass hyperresponders want to decrease their LDL, so they might try adding some carbs back. They might try a medication. Most of my lean mass hyperresponders are familiar with the content and maybe lean a little bit more towards the typical low-carb community creator and say, I don't care at all. At the end of the day, they're Luke Skywalker and I'm Yoda, meaning they're Luke Skywalker. This is their life. This is their battle. But I'm Yoda. I've been in that same battle for myself, and I have helped plenty of Luke Skywalkers in their battles. As you know, when I'm fighting for my own life, I have chosen to take low-dose statins. A lot of my patients do that. Some of them don't. That's their choice. They just need to be informed about what they are doing. And then they need to make their choice. So this is why I test deeply. This is why I don't just write prescriptions based on one number. And this is why I always tell patients, you're not your LDL. You're not your cholesterol score. You're a whole system. And we're going to treat that. So here's what I want you to take away from this. If your doctor's treating your LDL without checking your insulin, your inflammation, your metabolic health, you deserve better. Because true prevention means looking deeper, personalizing the plan, and treating the cause, not the number.
Tired of being told your labs are normal while you still feel off? Meet Dr. Ford Brewer, a YouTube sensation with over 600,000 subscribers, dedicated to helping you optimize your health and metabolism.
My team is offering free clinical consultations to create a tailored program just for you. Here are some of the most popular programs that we have. Comprehensive telemedicine care, including lab work, one-on-one consultations, and prescriptions. The Metabolic Reset Program. It provides fat loss, increased energy, longevity, weight loss, as well as nutrition and exercise plans. Personalized coaching with a world-class team of dedicated health advisors. They're handpicked and trained by me. A limited number of patients can actually choose to work with me personally. No guesswork, just real data, real care, and real results.
Call now and take control of your health today.
To know more about how I reversed my own plaque, beyond just looking at LDL, check out this video right here.